Welcome. So I'd just like to say I'm Gavin Giovannoni. I'm a neurologist based in London, and I'm chairing this session, but it's going to be very informal. It's going to be a discussion, and we do have a roving microphone, so if people want to ask questions, just put your hand up and we can interrupt. We've got a list of things we want to discuss, but it's not essential we get through them all. It's more about interaction, and this is about how we protect the brain in people with multiple sclerosis to try and optimize outcomes in the long term. And I'd like to thank Roche for sponsoring this and giving us the opportunity to talk about it. And as you can see, there are 3 women on the panel with me. Isn't that incredible? 3 women. And I'd like them all to introduce themselves, starting with Stanca.
Hello, everyone. My name is Stanca. I'm from Romania, and I'm an MS patient for almost 14 years now. I'm also the founder of Smile Center, a local counseling and support group for people with MS in my hometown. And that's pretty much everything about me.
Hello, I'm Riley Bove. I'm an MS neurologist at UC San Francisco in California.
Laura?
Very nice to be here, Gavin. I'm Leorah Freeman. I'm also an MS neurologist at UT Austin.
Its accent sounds European, or slightly European.
I try to hide it, but I'm actually a French girl adopted by the great state of Texas.
Okay. So welcome. So the purpose of focusing on brain health is because, as we get to manage MS better and better with our therapies, we have to go beyond disease-modifying treatments to focus on how we optimize brain health. And what brain health is doing all the things we can so the patient's brain functions to the optimal level for them to thrive, basically, for individuals with MS to thrive. And that means changing the way we approach the management of MS. So I'd like to go to Laura first and ask her, is it unrealistic in 2025 to expect somebody with multiple sclerosis to get to old age with a healthy brain?
No, I don't think it's an unrealistic goal. I think that, with our current disease-modifying therapy and what we know about brain health and lifestyle modification, I think that we're in a place to kind of shift the odds towards aging well with MS. But this requires, first, early diagnosis. It requires timely initiation of high-efficacy treatment, but it also requires a brain health-focused management of the disease that encompasses lifestyle modification, that encompasses management of mental health, and other aspects of brain health. So I think it is, and Stanca will probably confirm, that this is a goal of many of our patients to age well with multiple sclerosis, and we can empower them by transforming the way that we care for them.
So Stanca, do you expect to get to old age with a healthy brain?
Yes, of course. Actually, I am aging. Just like I've said before, I had MS for over 14 years now, and thank God I'm doing great. But just like Leorah said, I did some changes in my lifestyle. I had early diagnosis, and I acted promptly with treatment also. So I think all of these factored in to my well-being now, and I really hope I'll get to... I have a motto, I intend to live forever, so far so good. So let's see.
So Riley, maybe we should ask, but in your practice, now we're talking about when you see not newly diagnosed people with MS, let's talking about the follow-up. What do you do over and above what services do you offer over and above to optimize brain health in your patients?
I think I tell my patients that I have the benefit of time. So I have the benefit of seeing people at many different phases in their life. And I tell them that 70-year-old you will really thank 30-year-old you or 40-year-old you for the behaviors that you change now in terms of exercise, sleep, social connection, nutrition, mental health. If we can really focus on those early, we can really promote healthy aging. And so I lay that as a roadmap for them, as a goal. And I also say everybody's grandmother shrinks, right? Everybody's brain shrinks. We'll all experience aging, but we want you to do this in as healthy a way as you can. So laying it out up front for them.
Laura, maybe I know you want to tell them about the services you offer, because maybe you want to tell the clinicians in the audience or the healthcare providers what you do, what you offer in your practice as well for them.
Yeah, no, and it goes to conversation that we've all had is whose responsibility is it to educate our patients about brain health, to deliver brain health-centered care? And I think at least in the US, a lot of clinicians rely on the family doctor, the primary care provider. This is their job to do this. Or maybe the National MS Society will tell them what to do. But really, what I observe is that, for example, in the United States, a lot of primary care providers really don't have a lot of time. They have 15-minute visits. They cannot really engage. They don't know much about MS and how lifestyle impacts MS. Plus, I think, Riley, you and I have talked about this, about how patients look at us as their main doctor once they have MS. It is such an impactful diagnosis that people look at us as really having the answers. They want our guidance. So I believe that we need to bring those conversations within the MS clinic. And just like Riley said, education is critical. But we can even go beyond. A misconception that people have is that delivering brain health care is not something that we can reimburse for. It's not something that is that fits into the current, at least American model of business for healthcare. But the truth is that it is care that we can be reimbursed for. And at our center, we chose to bring into the MS clinic a doctor that I look at right here, who is a family medicine specialist, who is board certified in lifestyle medicine, soon to be board certified in obesity medicine, who's also is a person living with MS, to deliver patient-centered care through lifestyle coaching, one-on-one coaching, and also through group visits. That represent a very innovative model of delivery, what we call shared medical appointments, which allow multiple patients to see their doctor, the lifestyle medicine specialist, at the same time, to benefit not just from their individual medical guidance, but also benefit from peer support and kind of this collaborative care. And I think that this is a very valuable model to explore that is reimbursable and could really change the way that we deliver care within the MS centers.
Now, Stanca, can I come back to you? When you go and see in Romania, when you see your neurologist on your annual appointment or 6-monthly appointment, do you get a special section devoted to lifestyle medicine?
No, we don't. We might get a general question, how's everything else going for you? And you have to address it as a patient if you have specific issues other than the real MS troubles. But I wanted to add on something that Leorah said, that while it's true that we rely very much on our neurologists to coordinate this discussion for us, I think for an MS patient, the stress management, the diet, exercise, and lifestyle changes only become a concern of ours when it's a problem. We don't do it preventively to ensure we have a longer, better time with MS. We just intervene when it becomes a problem or we have comorbidities. So we diet when we're fat. We don't diet just to stay thin. That's the mentality, I think. And I think we have to change that.
So let's go to Riley. Riley, so I know that your interest is, women's health issues in MS. So menopause being the big elephant in the room. Maybe you want to give us some instruction about how you proactively manage menopause in people with MS.
So I really find that starting to talk about menopause when women are in their 40s, to say menopause is not, may not happen for another 10 years, 15 years, but I want you to know a couple things so that you are ready when it happens, because when women are not ready when it happens, what happens is you may have patients who've been very stable from a clinical standpoint, no relapses, symptoms managed, doing really well, cruising through their 40s, and then they kind of fall off a symptomatic cliff. And that's because perimenopause, when the periods are tapering out and ending, is associated with symptoms that overlap with MS: fatigue, lack of sleep, loss of libido, bladder symptoms, cognitive changes. And all of those perimenopausal symptoms, if patients aren't aware, they think their MS is progressing. They think they're getting worse. They think they're having relapses. And so it's really important that they understand that there is a big perimenopause contribution. And so that's a window of opportunity where we, again, go through all the symptoms and every 6 months revisit everything to try to coach them through their menopausal transition, using it as a window of opportunity to maximize all the health benefits, reduce the comorbidities, treat the symptoms, so that they can then move into their postmenopausal phase as healthy as possible.
So it's not just the usual lifestyle medicine things you have to think about. Now, Leorah, you mentioned earlier about what we call social determinants. So how many of you, just show of hands, ask about social or check for social isolation and loneliness in your patients? So there's a very few number of hands going up. So this is now a major social determinant. We know that people with multiple sclerosis, a survey done about 5 years ago in the NHS showed it was about 30 to 40% of people describe themselves as being lonely most of the time who've got multiple sclerosis. So unless you screen for that, you can't manage that. And there are services, at least where I work in the NHS, that you can have what we call social prescribing. So it goes much beyond what we would call typical lifestyle medicine. It's also looking at social determinants of health. Okay.
So I think that's really important. I mean, being a transplant from Europe, a nationalized healthcare system into Texas, which is a state that leads a nation in terms of poverty, in terms of people without insurance, in terms of, half of our state is medically underserved. I think this is a very important question to us. And, when we look at people who are affected by the social determinants of health, we're looking at people who not only have poor access to DMT, but on top of it, are much more likely to develop comorbidities that we know lead to accelerated rates of progression. So I think that when we talk about brain health, we cannot, separate this conversation from the conversation around social determinants and addressing these in our clinics, referring patients to social services, and really ensuring, because you can give all the advice you want, you can coach patients. I had a patient of mine who was very motivated to change her lifestyle. She was showing signs of early progression. She was affected by perimenopause. She wanted to engage in lifestyle modification, but her neighborhood was not safe. And her main barrier was that she could not go walk outside. She could not engage in physical activity. So it was very helpful for her to work with a lifestyle medicine specialist, work with the social workers, find ways to meet her goals with her challenges, really meet the patient where she is. So I think this needs to be a part of the conversation. I'm really glad you brought it up.
Riley?
Yeah, and one other thing about social isolation is I think the invisible symptoms of MS, as well as the mobility difficulties of MS, can be very socially isolating. So in addition to sort of having a support group for people in our area, I've started matchmaking with my patients, and that actually, with their permission, connecting them with people who have similar interests or life circumstances, and they've really loved it. They've made friends who can sort of go at each other's pace, because you don't often know who has MS in your community. It's so invisible. And that's been a really fun activity.
Yeah, I love this, Riley. Similar experience with our group, visit that we lead is those patients stay in touch for months, years. It's so powerful, that power of connection and feeling seen by others. So I love that you brought this up.
I totally agree with both of you. And actually, that's the reason why I started my counseling and support group for people with MS, so we could have a community where we could share our own experiences. And also, I think it's very important, speaking of isolation and all the other emotional baggage, that it's important for an MS patient to have the strength to be empowered, so they could take self-care, they could manage their own problems, and to have the courage to really raise up the questions that they need to address when they are in the neurologist office, because most patients just rely on their neurologist to bring up issues when they shouldn't.
Does anybody want to ask any questions? I see people nodding their heads, and I think there must be somebody in the audience who wants to make a comment. If, there's somebody on there. But
thank you very much, Tim Wölfle from Basel, Switzerland. Very interesting insights. You mentioned nutrition. I was wondering if there are also specific supplements that you recommend on top of vitamin D. There have been studies, for example, in the general population suggesting benefits of omega-3 acid in healthy aging. What do you think of this?
I generally, so there are some recommendations that can be valid in the general population that also apply to people with MS. For me, in terms of supplement, vitamin D is like a given for sure. I've also, on occasion, particularly people with heart health issues, hormonal issues, recommended omega-3s. CoQ10, there were some small studies done on CoQ10 and fatigue. And MS, it's also a good supplement for heart health. It's one that I recommend often. And magnesium generally helps with, muscle relaxation. It can help with some of their symptoms. It can help with anxiety. So that's usually one of my go-to.
And I would just add, I think in terms of the general diets that have been tested in terms of brain health in the general population, I think the MIND diet, the Mediterranean, and then sort of for heart healthy as well, is probably the one with the best evidence basis. So if I ask patients to do one thing, it's to stick with that.
Yeah, so we're talking about brain health here, but the brain is supported by the body, So, you can't talk about brain health without talking about metabolic health. Heart health, bone health, skin, particularly in more disabled patients, you've got to make sure they don't get pressure sores, make sure there's foot health, making sure they're able to cut their toenails, etc. So there's lots of other things that we should be doing when we're talking about the holistic care of multiple sclerosis. So I know the average neurologist in the NHS doesn't have time to do all those, but there should be some rapid screens you do to try and highlight some of the issues where you could at least signpost or refer people into. So, as a healthcare provider for MS patients, your job is to screen for lots of things. I'm not saying every neurologist should manage them all, but it's up to you to pick up that this patient may need a sleep study, for example, if you're really worried about them having sleep apnea. And if you put a cross-section of MS patients through a sleep lab, it's a ridiculously high number, about 40 to 45% will have obstructive sleep apnea. I think that's part of the disease, probably related to brainstem lesions. And it's also dissociated from obesity, so it's not the only obese MS patients have that. And that's something that most people don't screen for. So these are the types of things you have to actually proactively develop a program for screening for these things. Have you been screened when you go and see your neurologist? Do they ask you about your sleep when you see them every time?
Never.
Never?
No, I have never been asked how my sleep is.
Okay.
But I know sleep, at least for me, is very, very important. I have a 10 p.m. curfew every night.
So one of the things I do, not so much for like Stanca, if I've got a person who's disabled and comes in with in a wheelchair, I make sure I look at their toenails. Okay. A lot of people can make themselves look presentable, upper body, and you soon see who's neglecting themselves by looking at how they look after their feet. Okay. Now, podiatry in the UK is free for MS patients, but in some healthcare systems, it's not part of the healthcare. So you actually proactively have to look at all these little things if you want to promote holistic management of the disease.
Add gynecological health.
Fine?
I'd add gynecological
Yes.
health, which is completely neglected by neurologists, and it's very important to whole person care.
And a lot of I don't know what it is, but it's something about it's a cultural thing that women are expected to manage incontinence as part of being a woman. It's known, and they live with it, and they shouldn't have to live with being incontinent. You know what I mean? It's just not inappropriate. So unless you ask the questions, you don't get the answers. So this is why you have to have a structured pro forma where you screen people at every clinic, that you follow them up for all these issues. I'm sure I've left lots out, but anyway.
Yeah, and there's maybe kind of a future role of, you know, digital biomarkers or others that can help us also in tracking some of these factors and tracking patient or getting more information, more data from our patients that could help, you know, have reliable information about their sleep health, for example, so that we can know it is a problem. So I think that there might be a future that integrates some digital innovation that could be potentially very interesting in optimizing this communication of issues from between patients and providers. I know this is a hot topic for you, Riley.
To add one more, I would say I think MS is really a weather vane for what's happening in someone's body and someone's life in general. So when you're stressed, when you're unhappy in your relationship, when you have something else happening, the MS symptoms can act up. And so I think people knowing what their bad MS day looks like and being mindful when they have a bad MS day, that we can look through to see what actually is going on. It may be really a clue to other things as well that are very relevant for whole person care and brain health. So that, I would say, should be part of the conversation as well.
So we run out of time. So I just want to conclude. I personally think going beyond treating multiple sclerosis is actually part of our responsibility as healthcare professionals. But we also have to walk the talk, because when we talk about brain health, we're talking about population health. So unless you as healthcare providers walk the talk, in other words, you treat your own brain the way you want to treat your MS, they're not going to listen to you. So how many of you are proactive about your own brain health? Not enough hands. So you also have to walk the talk. In other words, you've got to make sure you screen yourself, prevent comorbidities. You've got to make sure you exercise, look after your diet, look after your sleep, make sure if you've got a mental health problem, get help, etc., etc. So this is also about some inner reflection. If you want to manage MS holistically, you have to manage your own brain health. So this is a population problem. So I'd like to stop there because we've run out of time. No more questions? Just maybe one question if anybody wants. If not, then we will close. I just would like to thank Stanca, Riley, and Leorah for an interactive discussion, and enjoy the Congress. Thank you very much.
Thank you.